Good morning, and welcome to Global Neurosciences Institute Grand Rounds. And now it is my great pleasure to introduce our speaker and my friend, Dr. Kamil Detyniecki. Dr. Kamil Detyniecki is an associate professor of clinical neurology at the University of Miami, Miller School of Medicine, and attending epileptologist at the University of Miami Hospital and clinics in Jackson Memorial Hospital. He is a director of the Clinical Trials Research Program in Epilepsy at University of Miami and is the principal investigator of several clinical research studies. Dr. Detyniecki was born in Venezuela. He earned his medical degree from the Medical University of Warsaw in Poland. He trained in neurology at Drexel University. Subsequently, he completed a 2-year epilepsy fellowship program at Yale University in New Haven. He was part of the Yale faculty from 2010 to 2018, where he directed the epilepsy clinical trials program for 7 years and led over 10 studies as a principal investigator. In 2018, he moved to the University of Miami Comprehensive Epilepsy Center. Dr. Detyniecki's research interests and publications include collaborations with other major academic institutions, including Yale, Columbia, Harvard, on topics like effectiveness and tolerability of anti-epileptic drugs, seizure clusters, and epilepsy surgery. He has directed symposia and lectured at many national and international epilepsy and neurology meetings. He is a fellow of American Epilepsy Society, where he is a part of the treatment committee. Dr. Detyniecki will be speaking today about seizure rescue therapies.
Well, good morning. Thank you, Peter, for the invitation and the kind introduction. And I'm happy to be here and to spend this morning and talk about seizure rescue medications, which is a topic that I've been studying in the past few years. And I think you will find it helpful. Today, I will talk about 2 seizure emergencies, the status epilepticus and seizure clusters, but I will focus on the pre-hospital treatment, which is where we use these seizure rescue medications. I will describe the current available rescue medications, focusing on the 2 new nasal options, and then I finish it with some exciting new rescue treatments in the pipeline. And these are my disclosures, and I have consulted with pretty much all the companies that are marketing rescue medications. And I would like to pause for a moment to remember our former neurology chairman, Dr. Schwartzman, and as all the alumni, which I've always meet, we're always very fond and proud to have been taught by this fantastic teacher. And I feel very fortunate to have been trained by him. And so is Peter. And I still frequently remember his teachings when I see patients in the clinic. And I don't know if many of you in the audience remember this place. I'm sure Peter does. And this is where we used to sit every morning with Dr. Schwartzman for morning report. And we use that blackboard to draw different nuclei of the thalamus and different parts of neural anatomy. Fun times. Okay, so I would like to begin by showing the scale of the problem that we're talking about today. So epilepsy is a common neurological condition. And so there's 65 million people affected worldwide with epilepsy, approximately. And we know about a third of those are drug resistant. So that makes about 20 million people that have uncontrolled seizures worldwide. So assuming an estimate that about 15% of epilepsy patients have at least one episode of status epilepticus in their life, and it's fair to assume that about 10 million people worldwide will have an episode of status epilepticus. So the goals of treatment in epilepsy, these are the ideal goals, we want patients to have no seizures and also no side effects and have a normal life. Now, despite having more than 30 anti-seizure medications in the market, many patients continue to have seizures. And this figure shows the results of one of the biggest prospective cohort studies done for 30 years. And in light gray, you can see the probability of achieving seizure freedom. which is about 50% for the first drug. And this dramatically reduces after failing 2 drugs. And as you can see, adding more drugs, it doesn't help a lot. And what's really interesting is that this study was by the same group published about 18 years earlier, and the results are almost identical. So it would suggest that we haven't made much progress with new anti-seizure medications. We still can make some progress in individual patients, but overall in epilepsy, we haven't been able really to make major impact with new anti-seizure medications. So I'm sure most of you know what the definition of status epilepticus. But to remind you and the trainees, we know that most seizures, generalized tonic-clonic seizures, last about 1 to 2 minutes. So status epilepticus is being defined operationally as having a convulsive seizure lasting more than 5 minutes. And if it's a focal seizure with impaired awareness, we define this as 10 minutes. And if it's an absence seizure, 10 to 15 minutes. Or status epilepticus is also if you have 2 or more seizures without full recovery of consciousness between seizures. Now, some of you may remember or may still see in old textbooks, the status epilepticus is defined as 30 minutes of convulsive activity. So why is this change now for 5 minutes? Well, there was a group of experts that met, and we saw the research and noticed that tonic-clonic seizures lasting more than 5 minutes, it's unlikely to terminate spontaneously, and there's consequences to that if we don't stop the seizure. The longer a seizure lasts, the more resistant to drug therapy and the harder it is to stop. And having this longer definition was felt that it would cause clinicians to delay treatment and wait for 30 minutes before they initiate treatment, and increasing morbidity and mortality. So the time is of essence, and I think the stroke world has made a good campaigning about the time is brain, and everybody knows that you have to treat stroke very quickly. We're still not there with the message for seizures, and it's the same problem. So during the first stages of convulsive status epilepticus, there's an increase in cerebral metabolism, increased blood flow, increased glucose and lactate, and those are compensatory mechanisms that are probably beneficial. They're trying to supply the brain with increased demand of the seizure. And that would cause hypertension, increased cardiac output, tachycardia, increased cerebral venous pressure. But after about 30 minutes or so, these compensatory mechanisms start to fail, and if seizures are not controlled, and that's when we start seeing cerebral damage. So the autoregulation fails, leading to hypoxia, hypoglycemia, increased intracranial pressure, and cerebral edema. So status epilepticus is associated with significant mortality and morbidity, and there are many factors that influence mortality in status epilepticus, such as age and etiology, for sure. But I wanted to point out that time is probably the only factor that we can potentially modify. We can make people younger, but we can potentially treat status as soon as possible and delay this and reduce that time. And so this is an old study from 2 decades ago, and we can see a clear difference in mortality when a seizure lasts more than 30 minutes and when a seizure lasts between 10 and 29 minutes. So I'm sure in your hospital you have one. Every hospital has a proposed algorithm for the treatment of status. There's plenty of guidelines. And here's an example of one proposed algorithm by the American Epilepsy Society. And pretty much in all these protocols, the initial phase of the treatment status consists of stabilizing the patient with your ABCs, airway, breathing, circulation. You have to resuscitate the patient, and then the initial phase is an administration of benzodiazepine. In the United States, we use intravenous lorazepam, intramuscular midazolam, or intramuscular diazepam. So I'm not going to talk about what you do later, and that will be a topic for another talk. But I will focus on that initial part, before the patient gets to the emergency room, before he gets to the hospital. So it's important to recognize some landmark studies that have looked into this treatment of pre-hospital treatment of status. So this is a famous study called the Rampart study, acronym for rapid anticonvulsant medication prior to arrival trial. And it was in 2011. And the purpose of this study was to prove that intramuscular midazolam was not inferior to IV lorazepam. At that time, and we still know, IV lorazepam is best, and it's very effective at stopping a seizure. However, it has its limitations because it's impractical. Very hard to put an IV line in a convulsing patient. So that was the purpose of this study, and the intervention was targeting paramedics that were getting 2 packages in a box. A very, very smart way to design this study, where they have an intramuscular autoinjector and an IV medication, and one was an active treatment and one was placebo. So patients, ethically will always receive an active treatment. And here's the doses for the treatments: the lorazepam and midazolam. Midazolam was the one that was intramuscular. So what was found? Well, it was found things that we kind of expected. So the time to cessation of seizures was faster for intravenous lorazepam once it was given. So it works fast. Intravenous works faster than intramuscular. Makes sense. So it was 1.6 minutes time to cessation of seizures for intravenous lorazepam and 3.3 minutes for intramuscular. However, intramuscular was administered faster, a lot faster actually. So 1.2 minutes versus 4.8 minutes. And at the end, that made a difference, because not only was non-inferior, but actually was slightly superior at the end. So at the time of arrival to the emergency room, intramuscular midazolam treated patients terminated their seizures in 73% versus 63% in the intravenous lorazepam. Here's again a graphic representation of what I just said, that intravenous lorazepam, this is time, from the active treatment to cessation of convulsions, it was faster than intramuscular midazolam. However, from the time from box opening to cessation of convulsions, it was faster with midazolam. And the difference is because you can administer a lot faster. So there's because of this study and other similar studies, most guidelines included intramuscular treatment. So this is an example of, again, American Epilepsy Society guideline for first-line therapy options for pre-hospital treatment of status, includes intramuscular midazolam. And remember these doses for the next slide. So 10 milligrams is the recommendation of midazolam, AM, lorazepam 4 milligrams, diazepam 6 to 10 milligrams. I want to remind you that the currently approved rescue medications, nasal midazolam and nasal diazepam and rectal diazepam, are often used to treat status, but has not been studied for that, and they're not FDA approved for treatment of status specifically. So how does it look in real life? Well, the authors of this study published in JAMA Neurology a few years ago, 2 years ago, looked at an electronic health database used for several emergency medical service agencies in the United States. and they look at what medications were actually given for the treatment of status. So they look. So here you can see there's about 9,000 pre-hospital encounters, 743 agencies, and they looked for a period of 1 year. So here's the different medications, and here's the different routes and the different doses. I marked in red here what was the guideline for this medication on from the previous slide from the American Epilepsy Society as a reference. And what you can see here is that the majority of patients were treated with a lower dose of benzodiazepine than recommended, or using a route that it's not recommended. So, for example, here, intramuscular midazolam, you remember the guideline says 10 milligrams. Well, only 4% of people received that dose. Majority received, 5 milligrams and were treated with other things. Intravenous midazolam less than 5 milligrams. Same with lorazepam. Majority got 2 milligrams or less, and so on. So people are undertreated, and why that may be? Well, one of my suggestions, what I think it's probably related to concern for respiratory suppression. And that's something that I hear a lot in the emergency room, and emergency room physicians are scared of giving more lorazepam because the patient may stop breathing. It's a true concern. Of course, these medications are respiratory suppressors, but a seizure also affects breathing. So, and in fact, probably to greater degree. So in a landmark study of pre-hospital treatment of status, where IV lorazepam was compared with IV diazepam and placebo, respiratory distress was twice as common in the placebo group compared to benzodiazepine group, suggesting that the seizure by itself, it's worse for the maintaining the airways. And also, these new trials that are being published that I'm going to talk about today briefly on the nasal rescue medications, trials with rectal diazepam, there were low rates of clinically meaningful respiratory depression. So I think it's something that to keep in mind, but we don't want this to stop you from treating status. Now let's switch and talk about a different seizure emergency. We'll talk about status, and let's concentrate now on seizure clusters. So seizure clusters is not as well defined, and that's one of the problems when we look at the literature, at the prevalence and the consequences and all that, because there's multiple terms used. People use acute repetitive seizures, serial seizures, cyclical seizures, flurries of seizures. There's not an international league against epilepsy, which is what defines many of the classifications of seizures. They don't have a classification of what seizure cluster is. It may occur with any seizure type, and this does not include status. So for seizure clusters, patients recover between seizures, and in status you can have multiple seizures, but the patient does not recover between seizures. So prevalence, like I said, it's difficult to establish, and it's a wide range in the literature because it depends on the study population that was looked at, outpatient versus epilepsy monitoring unit population, and also because of a lack of unifying definition. So my best estimate after reviewing the literature in one of our prospective trial that I did when I was at Yale is that this is quite common in refractory epilepsy patients. About 40% of patients will have a cluster in a given year, and therefore for all epilepsy patients, about 13% may have a cluster, and so that makes about 425,000 patients a year in the US. So it's not rare. And the main risks for having clusters is, of course, having had clusters before. That's one of the biggest predictors that we found in having frequent seizures. What are the consequences of clusters? Based on mostly data from retrospective studies showing that there's high risk of status epilepticus, emergency room visits, injuries, loss of work, lower quality of life. Interesting, one study showed that the outcome in epilepsy surgery in temporal lobe epilepsy may be better in people who have clusters. This is a prospective study that I did when I was at Yale, where we looked at the prevalence of clusters prospectively using diaries for 1 year. I can tell you, doing studies with diaries, it's very difficult and cumbersome. It's a lot of data and a lot of tracking. And what we look at the patients we divided in 3 different groups. One's based on their seizure frequency before they enter the study. So people who were seizure-free were low risk, seizure-free for a year. They all had epilepsy, but they were seizure-free for more than a year. They were felt to be low risk. Intermediate risk are people who have seizures but never had a day with 2 or more seizures, so haven't had a cluster in a year. And high risk are people who had clusters before. So as expected, the prevalence of clusters as we follow them for a year was higher in the people who had clusters and lower in the people who were seizure-free. But interesting, 30% of patients who didn't have a cluster in a year developed clusters in the year that we watched them. So overall, again, 45% of active epilepsy patients had clusters. Again, this is a study done in an epilepsy center, tertiary epilepsy center, so may not reflect what we see in the general population. Patients tend to be more refractory. What was interesting, this was published right before the new nasal medications came to the market, so things are going to look different now. But it was still interesting in a big epilepsy center like Yale, and the rescue medication use was very small to these refractory patients. Only about a third had a rescue medication prescribed, and during the year of the study that we're watching them, only 11% of the patients used the rescue medication. At that time, most of them were oral lorazepam. We were using nasal midazolam off-label from compounding pharmacies, and in very small number of rectal diazepam. Again, this is a patient, adults. Adult patients really don't use very little rectal diazepam for obvious reasons. So what is an ideal rescue medication? Well, it should be effective for multiple seizure types and should work fast. Ideally, have minimal adverse events, easy to use, because people who are not medical trained should be able to use it in school, in summer camp, and should require minimal patient cooperation. Ideally, have a long shelf life. For a rescue medication to work, you should have a rescue plan. And that's something that pediatric neurologists are much better than us adults, mainly because in school requires them to have a rescue plan. Many schools require them to have a rescue plan. In adults, is really, really underutilized. And because now we have these better rescue medications that are easier to use, that are not rectal, and we start pushing to people to use these seizure action plans more often, because it really helps with communication with the caregivers and the patient, and when to call 911 and when to freak out and when to use the rescue medication, because it's really individualized for each patient. So the currently approved rescue medications, you're all familiar with rectal diazepam that's been available in the market for a long time. And now in the past few years, we have these 2 intranasal medications that come with the same device. The device is the same. What changes is the medication inside, and one is the midazolam and one is diazepam. In Europe, we have buccal midazolam approved for rescue treatment, not in the US. And there's some exciting drugs in the pipeline some of which I'm involved in the development, and I'm going to talk to you about those as well. So why nasal? Well, nasal administered drugs are much easier to use than, for example, rectal. And for a seasoned patient, it's also better to use than oral, and it works faster. So how they enter the brain, and what's important for the onset of action of these drugs is the time from when you administer to the time it reaches the target, which is the brain. And the majority of these medications are absorbed through the systemic circulation, through the mucosa, but also part of it gets swallowed, and so it gets absorbed through the GI tract. But there is also absorption that can occur directly through the olfactory trigeminal neuronal pathway. It's unknown to what degree that happens. It's been proven in rats, and there are some studies undergoing to try to show it in humans as well. So what's the efficacy for these two newly approved nasal drugs? I'm gonna start first with the nasal midazolam rescue medication, and I was involved in this study as well. So it was a study that was done where patients had received a box that had two treatments, kind of similar in a way design as a Rampart study, where one medication is an active treatment, another one is placebo. For ethical reasons, we can't leave people now without treatment. And the treatment success was defined as cessation of seizures within 10 minutes and no recurrence of seizures from between 10 minutes to 6 hours after the study drug administration. And then those times were chosen sort of arbitrary based on the known pharmacokinetics of midazolam. And these studies are difficult because there's high placebo response, and the placebo response is not the typical one that we sort of know about, sort of psychological. Of course, it may happen as well, but it also has to do with such a wide variability of seizures. So seizures end spontaneously, clusters end spontaneously. So if a seizure stops and you receive placebo, that's a placebo responder. So these studies are very hard to conduct, and patients have to be very highly selected to have predictable clusters. So it's an unpredictable disease, epilepsy, but in some patients they have well-established clusters that last for a long time. So those are the ideal patients for studies like this. And luckily, I mean, this was for regulatory purposes. We had to do it this way, but luckily the patients were treated with the midazolam were more effective than the placebo. The adverse events, as you expect, there's nasal discomfort, and some of these medications are mixed with different type of solvents and alcohol solvents that may burn your nose, and so that causes lacrimation, nasal discomfort, abnormal taste, and somnolence, of course, based on the mechanism of action of benzodiazepines. For intranasal diazepam, the company had a easier way to do it. They didn't have to prove efficacy because we have already an approved rescue medication with the same medication, diazepam, so rectal diazepam. So the FDA has a pathway. It's called the 505(b)(2) pathway. It's a streamlined application to get approved drugs faster that they already have. It's an improvement of a currently approved drug. So for example, if a company tries to make a generic drug, they go through that pathway. And what they need to do is show that it's that has the same bioavailability. So that's what they did. They tested this drug in healthy people and people with epilepsy. They had to prove that the absorption was the same during seizure and in between seizures, and because there was a concern that maybe during seizures with the sympathetic surge, there may be different absorption of medications, and had actually very good bioavailability, and it was better than actually rectal diazepam. They did studies comparing with rectal diazepam. They had a little problems initially developing this drug because of the absorption of diazepam was not getting through, and they modified and they have this an absorption enhancer that they added to this medication that helped them get it absorbed. And adverse events similar to the other medication, somnolence, of course, and nasal discomfort. So now I would like to pause for a moment and think about what the goals of treatment are for each of these seizure emergencies that we just talked about, status epilepticus and clusters. So in the case of seizure clusters or acute repetitive seizures, we're typically not aiming at stopping an ongoing seizure. The seizure already happened and may happen again soon. There's high risk that it's going to happen again soon. So the goal of treatment is to delay or prevent the next seizure once the pattern is recognized. Or if we can stop the next seizure, at least decrease the severity or duration of the next seizures. And by doing that, hopefully we reduce injuries, decrease time to return to full functionality of the patient, and avoid other problems that can happen with clusters, such as postictal psychosis that is seen more in people who've had a cluster. And these medications are used, usually peri-ictal or post-ictal, right? Not during the seizure. And the onset of action of these drugs is a couple of minutes, about 10 minutes. And I'm going to talk about the onset of action soon about these drugs. Now, in the case of status epilepticus, it's a little different. The goal is actually to stop the seizure. The patient is seizing in front of you and you want to stop it. So we use, IV anticonvulsants or intramuscular medications and cardiopulmonary support. And the goal here is to reduce brain damage that can happen with prolonged seizures and shorten the duration of hospitalization, etc. And the medication is used ictally, right, during a seizure. And we want this medication to work as fast as possible. So less than 10 minutes for sure, ideally within 1 minute, 2 minutes, whatever the shortest we can get. But there's also seizure emergencies that have an unmet need, or maybe they're not called an emergency, but it's a problem. So for example, a single prolonged seizure that lasts more than 2 minutes, that has not yet progressed to status epilepticus. So for generalized tonic-clonic seizure will be 5 minutes, or a focal seizure less than 10 minutes. So someone has a focal seizure lasting 8 minutes. Well, it's a long time to have a seizure for 8 minutes. And if we get strict to this definition, well, they're not in status. So what do we do with these patients? Or patients who sometimes have prolonged focal seizure or a generalized tonic-clonic seizure that is preceded by an aura or a flurries of absence or flurries of myoclonic seizures, and then they have a convulsion seizure. So they know the big seizure is going to happen. And can we do something about it? Well, there's discussion about doing something for them, and rescue medication in that case will be used possibly ictally or peri-ictally, but the onset of action has to be very fast, because we're talking about a seizure. If a seizure lasts, we're talking about a seizure less than 5 minutes, so the onset of action has to be ideally less than 2 minutes. So do we have something like this? Here's again a graphic representation of what I'm talking about. On the right side here with green, every green line is a seizure. That would be a cluster of seizures, right? Acute repetitive seizures. And with those, the medication usually around the seizures to stop the next one. And here we have a case of status epilepticus. So one solid line will be a continuous seizure activity, and we use the medication to stop the seizure. And that will be, for generalized tonic-clonic seizure, will be more than 5 minutes. And there's something that we now calling REST treatment, so rapid epileptic seizure termination, which is a term used to this prolonged seizures that we want to stop really fast. So the characteristic for this rapid epileptic seizure termination, as the name says, it has to be fast, it's equivalent to intravenous medication, but it has to be easier to use. People are not gonna have an IV at home, and it should be non-invasive, and it should be able to be used during a seizure or around the seizure, and portable, easy to use. So do we have something like that? Well, the currently available seizure rescue medications may not be the best suitable candidates for REST treatments, although they haven't been studied in that indication. But we know that the therapeutic drug concentration during the window of opportunity that we talk about, less than 2 minutes, may not be high enough to stop a seizure. Anecdotally, some patients tell me that they use their nasal medication and the seizure stops within seconds. And that's anecdotal, but it's something that it's a topic of research, how quick these nasal rescue medications work. But we think it's not that fast. It's probably more than 2 minutes and more closely to 5 or 10 minutes. And so let's talk about the time of onset of anticonvulsant activity for these drugs. So the time of onset of action is mainly related to the time required for the drug to be absorbed from the site of administration, the nose or the muscular area where you inject medication, or rectally, to the time it reaches a clinical relevant plasma and brain levels. And we don't know the exact time of onset for many of these rescue medications, but it's important not to get confused with Tmax. So many times people look, well, the Tmax for diazepam is 90 minutes or something. So that means the medication takes 90 minutes to work. No, we know that that's not the case. We know that it's clear that the medications work faster than the Tmax. And by the way, for trainees, Tmax is the time of the maximum concentration of the drug in the serum after it's administered. So this is a really old study from 1980s, but I think it's very interesting what I'm showing here by Milligan. And a diazepam solution was administered rectally. They didn't have diastat, so it was preceding those times. But a diazepam rectal solution was given 20 milligrams rectally in 10 epileptic patients that had frequent spike and wave discharges. And there are people like that. Sometimes we call it spike and wave stupor. That constantly happens, spike and wave, and then measured the serum concentration of the diazepam, and you can count exactly the spike frequency, and that's interesting because it's more of a biomarker of the medication getting to the brain and actually doing something to the seizures, or at least to the spike wave. So, and he found out that first of all, that the spike count drops much earlier than the Tmax. So in the white color here, it's the serum concentration, and it continues here. Here's 30 minutes, and it probably goes up a little bit longer sometimes. And this is the spike count initially, 100%, and then drops quite quickly. And so at 5 minutes, the spike count fell almost 50% compared to baseline. And that is at a concentration of diazepam of about 30 nanograms per ml. In animals, this is a study where these rats were continuously infused with diazepam at different concentrations, and they were measured in their blood, and their threshold to seizure was measured, the threshold to chemically induced seizure. So there's a rat model called pentazole model, and you can reliably trigger different type of seizures and behavioral and on EEG with this chemical, and you can measure the threshold to get a seizure with this chemical, and how it's changed with diazepam at different concentrations, and he found out that the concentration needed to elevate the seizure threshold was at 70 nanograms, which was much lower than we previously thought. And I'm comparing here, I mean, humans are not the same as rats, but we're quite similar to rats in many ways. And here on the right side is a pharmacokinetic study in humans, healthy volunteers, showing how, again, how quick the concentration of diazepam in the blood after you give it intravenous, nasal solution or suspension. And what I wanted to show here compared to this is the 70 nanograms, it's quite fast to reach that concentration with, let's say, with the nasal administration. Clinically, in different studies, seizures can be stopped within 3 to 5 minutes. It's faster IV followed by nasal and then rectally. So in this one study, the time to stop a seizure, was about 4 minutes plus minus 3-4 minutes with IV lorazepam and almost twice as much with diazepam rectal gel, and here rectal compared to IV. Sorry, I think this is not meant to be with intranasal midazolam. It was comparable, a little bit faster for intranasal midazolam, about 3 minutes the median time. So, what are potential candidates for this rest treatment, for this really fast rescue medication that can stop an ongoing seizure? So, in the 1990s, the Department of Defense developed a diazepam auto-injector to treat seizures and other sequelae associated with nerve agent intoxication. And they had this FDA approved for these emergency situations. And afterwards, some studies have shown that midazolam IM may be a little faster than intramuscular diazepam. So the Department of Defense initiated a program to develop midazolam auto-injector. And there's a lot of talking in the epilepsy community that, well, we should use this for status and not wait until the Russians attack us with a nerve agent or something like that. So this is an example is the Rampart study as well. And the onset of action for intramuscular midazolam is felt to be about 3 minutes from the Rampart study that I showed you before. And here on the right side are other potential different companies looking at other ways of delivering medication. This is an auto-injector that is needle-free, so it uses technology that through very small, tiny holes under high pressure delivers the medication subcutaneously or even deeper intramuscular, but without a needle. I mean, at the end, I think it probably hurts the same to get the medication this way or with the needle, but there's a lot of patients with needle phobia. So, and the idea is for the auto-injectors, all of them, that you can administer through the clothes as well, in a case of an emergency. So this is what studies that were funded by the Department of Defense and looking at intramuscular, what the pharmacokinetics is of intramuscular administration of midazolam with an auto-injector and different doses. As you can see, you reach therapeutic drug concentration within minutes, very fast. Now, this device is really exciting for me. It's still in the development. It's called a staccato device. So it's a novel delivery mechanism that is this device is placed into the patient's mouth and gets activated with a normal breath. and creates an aerosol of the drug. So it hits the surface here inside that's coated with the drug. And with a normal breath, it allows to deliver deep into the lung these small particles of medication, and that gets absorbed really fast. The lung has a very large surface of absorption, and you get medication delivered very quickly. And the onset of action is comparable to IV, but without needing to have an access like that. And this recent publication is a phase 2 study that was done in epilepsy monitoring unit, in which patients with predictable prolonged seizures or seizure clusters were treated with this device under supervision, and with the research nurse, research staff. And the primary endpoint was achieved, which was the proportion of patients with cessation of seizures within 2 minutes after administration of this study, and no recurrence of seizures within 2 hours. You may wonder again, looking at this graph, well, the placebo response is very high, 42%. It's high, and because of mostly because of the variability of seizures. Seizures, as much as predictable as we want them to be, they may stop earlier, and then you have active placebo responders. And the time to cessation of seizures was 30 seconds for this stacarylprazolam compared to placebo. Now there is an ongoing large phase 3 study, and that is being conducted targeting specifically prolonged seizures, because this drug, it makes sense to use it for prolonged seizures, not for clusters. So there's still many unanswered questions about the rescue medications that we have. Like I mentioned, we don't know exactly when they start working in the duration of action. And it's not the same as the half-life or the pharmacokinetics. We know from midazolam, for example, it has a short half-life, but people don't have seizures for a while afterwards, which means there's also the effect of interrupting the cluster early that can help prevent seizures afterwards. Can they alter the natural history of seizures? That's an interesting question. We've seen with studies looking at patients who keep using these rescue medications that they're using it less often, and we don't know why. One explanation is they just learned to use the device. Initially, they were using it more often, then they got used to some kind of behavioral thing, or maybe they're having less clusters somehow. And that's why they're using it less. We don't know. What is the best choice for a given patient? Should I give them intranasal midazolam or intranasal diazepam? Which one is better? Should we use it differently with patients who have a prolonged, like long clusters that last for days, and diazepam has a longer half-life? So maybe that's how I use it, but there's no data for that. And maybe midazolam, because it's shorter half-life, we should use it for shorter clusters, and maybe will allow patients to recover faster from the sedation from the medication. This chronic benzodiazepines has an effect, and this fasting have an effect because some of this medication gets swallowed. So there's a lot of questions. Some of them are getting answered. Here's a study showing the effect of chronic benzodiazepine on the use of the second dose of a cluster of a rescue medication, because these rescue medications, you can use a second dose after some time if the first one didn't use. So that's a proxy for effectiveness. If the first dose worked, then you don't need the second dose. And they looked at the proportion of patients that use the second dose in the ones who are on chronic benzos, the one who don't, and they didn't see a difference, suggesting that it may not make a big effect. And the last few slides, and quickly, I know we're running out of time, but I want to talk about seizure forecasting, because that's also an exciting field and maybe related to rescue medications. So, the lack of predictability of seizures is probably one of the worst aspects of epilepsy. People don't know when they're going to have a seizure. They can't get prepared. And the seizure forecasting is a field, associated a lot now with the devices and machine learning. and it may be possible in the near future. We're getting better at this, and this could help prepare a patient for a seizure and, for example, use a rescue medication. So on one hand, we have invasive devices more and more used in epilepsy patients, implanted in their brain that continuously monitor electrical activity. And this was a study that did not progress into the market, but there was a device that was implanted in the brain and gave a patient like a little sort of a pager in different colors. And when it was red, it was high risk for seizure, and green was that it had low risk of seizure. And on the right side, it's I'm showing here non-invasive wearable devices that are commercially available, seizure watches. These are used to detect seizures. They use accelerometry, heart rate, electromyography, electrodermal activity to detect seizures. And they're becoming better at doing that. And these devices are being studied using machine learning to learn from a given patient to forecast seizures. And this is one of our patients that have a responsive neurostimulator implanted neuropace that detects seizures and sends an electrical current in response to seizure. And look how these are detections of what we call long episodes, which are episodes of continuous electrographic activity lasting for 20, 30 seconds. And they're a good marker of seizures. And you can see here how cyclic they are in this particular patient. And so many studies have shown the seizures are not always random. They may occur in cycles, and not only in women. Women with hormonal changes during menstrual cycle, we know about catamenial seizures, but also men have these. And it can happen within a day. So here, the same patient, this is the number of detected episodes by the device per hour, and each line is a week. And here's you can see it's very small maybe, but this is the time of the day, 12 a.m. Here's 10 a.m., 11 p.m. So look at, there's more activity at night and less during the day. So these kind of patterns, it can help us as well to try to predict seizures. So in the near future, an epilepsy patient may look like this. Have an implanted device that can help him, tell him he has a seizure, maybe a seizure watch. He's going to have a seizure action plan in his pocket, and a variety of different rescue medications that can use depending on the type of emergency that he has. Thank you. This is a recent trip that I took in Springs in Florida, and this is my dog fetching a stick.
Well, that looks great. But Dr. Detyniecki, thank you very much. I mean, it was actually a really, really great talk. I think it made you think, on a big scale, are you guys trying to change the paradigm or overall our clinical thinking? It made me think a little bit more like when we evaluate the patient with migraine automatically, as we start thinking, okay, what's for this abortive agent, what's the preventative agent, and should we start thinking, in epilepsy patients, okay, we all prescribe anti-epileptic medications, but should we also start, automatically thinking, should this patient get one of these, the abortive medications for seizure as well? So I think that's really exciting, direction you guys are taking. We have some questions, so I'm just going to dive in right into them. So the studies that were done, were those studies done in the controlled environment, meaning in the hospitals, ambulances versus home, or the ones that evaluated, the effectiveness of these, abortions?
Yeah, most of these studies, the initial part is, the earlier stages are done in a controlled setting. Like, for example, the intranasal midazolam, there was a study in the epilepsy monitoring unit, but then they have to be evaluated in the outpatient setting to see how practical it is. Mm-hmm. And the saccharomolprazole, I show you this patient, the video, that was in a controlled setting, right, in the hospital. And now there's a phase 3 study to evaluate how it's going to work at home.
How frequently do you right now prescribe these medications for your epilepsy patients?
Well, a lot more than before. And when we have only rectal diazepam, we almost didn't use it. I mean, we use oral lorazepam. Some of us use off-label midazolam in a spray, but that was difficult to use. It was IV basically IV midazolam in a syringe that you spray into your nose. So it was large volume. It was dripping down their nose. It was burning a lot. The pH was very low, so it was burning. So yeah, it wasn't the greatest thing. So I think, probably if you think about the patients who need rescue medication, definitely the ones who have refractory seizures, they should all have. People who had clusters before, people who have status epilepticus, for sure they should have. They all should have. But what about the ones who, patient with juvenile myoclonic epilepsy that is young in college, sometimes gets drunk and didn't take his medication and has a cluster of myoclonic seizures and gets a generalized tonic-clonic seizure. I think this one should have also rescue medication for those situations. I'm proposing that maybe we'll get to the point that everybody should have one, sort of as an emergency.
I think it totally would make sense. It totally would make sense. It's just, the finding the candidate, because if somebody doesn't have any aura and live alone, and they just go into a seizure, but is there support system, not support system, and all the other factors. But overall, I totally agree.
An EpiPen,
Yeah, Now, another question: mental status. So that's where it comes in. You give these sedative medications. They stop seizing. They don't look like they're seizing. They're very lethargic. So is it how to really, and then that for people to make a decision. Okay, should I actually take this person to the hospital or not? Because are they lethargic because of their in status, or lethargic because of the medication?
That's why it's so important to have a seizure action plan where you can discuss this with the family, because every patient is different. So if a patient, and that's why it has to be individualized. If a patient always takes him half an hour to come back to normal, then if it's 20 minutes, then you're probably okay. That's what the previous experience was. But if it normally takes him 2 minutes to recover, and now it's half an hour later and the patient is still altered, then they should go to the emergency room and be connected to EEG to make sure they're not seizing. So that's why there needs to be that conversation with the doctor and the treating neurologist, and to know what the patient's pattern is.
Have you encountered respiratory distress in patients who administer that to at home, these medications?
I haven't seen it. Sometimes we do a test dose in the office if we're worried about people who are very frail, low body mass, and then I say, let's come here, let's do a dose here and see how the patient reacts, even if he doesn't have a seizure. We're just giving the test dose. That's something that we can sometimes do. If a patient is on, one concern is opioids. Opioids with benzos are not good. So there are patients we would not prescribe this. If they're opioid abusers and things like that, and probably not the best thing.
And I know we passed the time, but we have so many questions, I'm going to squeeze in a couple more. What rescue would you advise at outpatient imaging centers? Lorazepam, midazolam, how much?
For imaging?
Outpatient imaging centers, in case they have somebody seizing, is it lorazepam? Is it midazolam? How much? Do we know the answer?
Yeah. I mean, I think, the oral medications take a while to work. So for something like an imaging center, if you want something to stop faster, probably the nasal would be the best. But you need to get it approved probably through your institution. But in many epilepsy monitoring units are start using intranasal ones instead of the IV lorazepam that we normally use, and it's working.
If treated pre-hospital, are you seeing better response to overall treatment of the patient in the hospital? If treated pre-hospital with these, medications.
Oral at home versus oral in the hospital.
Yeah, and if they are treated before they show up to the hospital, do they overall have a better outcome? Treatment.
Yeah, absolutely. So oral medications still have their role, and if the patient has clusters that occur every hour, for example, there's no need to use nasal. You can use it oral. Lorazepam, you're gonna get it to the brain before the next seizure. So absolutely, if they can start treating their clusters before it gets worse, they will do better.
And a history of or did you encounter anybody abusing these medications?
Yeah, that's a good question. It's always been a concern. In the faster these medications act, more concern, right? When I
Mhm.
thought about inhaled alprazolam, I was imagining, oh my God, people snoring these things. Definitely, there's a concern for that. It can happen. We don't see that a lot, and I think mostly because of the how controlled these substances are and how many they can get. Number one, they're very expensive, so it's hard for patients to have a lot of accessibility there. And we control how many they get per month. If somebody is using it, every week or more than that, it can mean that they're abusing or they're having seizures too often and they're using it wrong. Then we should do something different. Like these medications are not meant to be used daily or something like that. So there is a potential concern for abuse for sure, but it should not prevent you from using it when needed.
Dr. Detyniecki, thank you very much for this great talk. Have a good day, everybody.
Thank you, Peter. Have a good day.